Welcome back, ladies and gentlemen, to the Your Go-To Doctor YouTube channel. I'm Dr. Robert Feldman, board-certified neurosurgeon, today talking about cubital tunnel syndrome. That's right, cubital tunnel syndrome. Not carpal tunnel syndrome, but cubital tunnel syndrome. Cubital tunnel syndrome is basically pinching of the ulnar nerve, which is otherwise known as the funny bone nerve in the elbow. Now, technically, that nerve can be pinched in any spot along its course, but other spots less common than the elbow location or cubital tunnel is a location in the wrist or a location in the underarm. But this talk is going to be about cubital tunnel syndrome, where the ulnar nerve is pinched in the elbow, the most common location for that pinching. We'll talk about why it happens, the symptoms that you get from it, your options for treating it, including the surgery. So stick with it, watch the video, and let's get to it. Cubital tunnel syndrome. So probably almost all of us have hit our funny bone. We basically hit a certain spot on our elbow and we get a zinger of numbness and tingling, or maybe pain, down our forearm into our last two fingers, the pinky and the ring finger. That is basically you bothering the ulnar nerve as it runs through a very shallow point across your elbow. Now, cubital tunnel syndrome, which is pinching of that ulnar nerve in the funny bone area of the elbow, because that area is called the cubital tunnel, is actually the second most common nerve pinching problem in the arm. Carpal tunnel syndrome, which I talked about in a different video, is pinching of the median nerve in the wrist. Cubital tunnel syndrome is pinching the ulnar nerve in this groove right in the elbow here, between the two bones of your humerus and your forearm. So that pinching of your nerve right in that little groove there is called cubital tunnel syndrome. And that's basically what we're going to talk about today. Now, granted, that nerve which runs through the cubital tunnel, the ulnar nerve, comes from the nerves in your neck. Basically, C7, C8, and T1 nerve roots in the neck contribute fibers that eventually form that ulnar nerve. So technically you can get symptoms running down your forearm into the pinky finger and the ring finger from pinching of that ulnar nerve anywhere in the arm. But that spot in the elbow is the most common. So now let's talk a little bit about why that happens. So most cases of cubital tunnel syndrome are idiopathic, which means no obvious cause is eventually found. But it can be related to trauma, and that trauma could be remote, meaning far in the past, and that includes fractures of the elbow bones directly damaging the nerve. Or, and this is what I believe, is a lot of times cases that are considered idiopathic are really from a funny bone incident in the remote past. So 5-10 years before you start getting symptoms, you hit your funny bone on something, you get those symptoms shooting into your pinky and ring finger. It goes away in a minute or two and you feel fine. But in the meantime, you've bruised or damaged the tissues in that cubital tunnel area, and scar tissue forms. And over the years, that scar tissue kind of contracts and organizes, and eventually you get to the point where a band of scar tissue forms across that cubital tunnel, and the nerve gets pinched to the point where you develop symptoms. And oftentimes when I operate to unpinch that nerve, I find a very focal band of connective tissue or scar tissue that's kinking the nerve in that cubital tunnel area. So my theory is that you hit your funny bone 10 years earlier, and the scar tissue over time eventually got to the point where it's causing symptoms. And that's the typical reason for a cubital tunnel syndrome. Now keep in mind, injury or swelling to the muscles that the nerve comes out of in the upper arm or goes into in the forearm can also lead to pinching of that nerve just before or after the cubital tunnel. It'll give you the same type of symptoms. So when I do unpinch that nerve during surgery, I will usually follow it up to the spot in the muscles it comes out of and down to the spot into the muscles it goes into, to make sure that that little band of connective tissue is nice and loose around that nerve. So that's basically why you get a pinched ulnar nerve in the elbow area. Now let's talk a little bit about the symptoms that you'll get. So what are the symptoms of cubital tunnel syndrome? Well, interestingly, pain is often not the primary symptom or presenting symptom. Usually it's numbness, tingling, or weakness. But if you do get pain, it'll typically be a very focal pain, often pretty severe to the touch in that cubital tunnel right here in that groove. So that'll be painful to the touch. And you can get pain shooting down the arm into the fourth and fifth digit, pinky finger, ring finger, but that's typically going to be more of an aching sensation. The numbness and tingling, which is a predominant symptom, will run down from the elbow into the, again, pinky finger and ring finger, but the numbness will often be only on the pinky side of the ring finger. The numbness can be worse with cold temperatures. It can be worse at night and wake you up at night. It'll often be worse if you're actually putting pressure on that area of your elbow. Weakness, which can sometimes be the presenting symptom, will often lead to various signs that can be picked up during the physical exam, and you can look these up if you want, but those include things like the Wartenberg sign, the Froment's sign, and the claw deformity sign of the hand. And these are usually due to weakness of muscles that are specifically innervated by the ulnar nerve. A very common muscle that often shrinks up in ulnar nerve injury or compression is this little area here in between the thumb and the index finger. So these muscles will get atrophied, as well as some of these muscles in between the fingers on the back side of the hand. The Froment sign is where you have an abnormality of your ability to pinch, for example, the pinky and the finger together, or the pinky and the index finger together. The thumb and the index finger, or the thumb and the pinky, for example, holding a sheet of paper. Instead of being able to pinch or grasp the piece of paper like this, you're going to end up doing it like this with the ball of the thumb instead of the tip of the thumb. And that's because of a specific muscular weakness from the ulnar nerve that innervates that particular muscle. But you can look those up if you want. Wartenberg sign, Froment sign, and claw deformity sign from ulnar nerve injury or damage. So pain, numbness, tingling, and weakness are the primary symptoms that you can get when that ulnar nerve is pinched, with numbness, tingling, and weakness being the most common. So the typical patient that comes into my office with cubital tunnel syndrome has already been diagnosed with cubital tunnel syndrome by somebody else. Usually what happens is the patient's symptoms are a pretty telltale hint as to what's going on, but oftentimes they will complain to their primary care physician or physical therapist or something like that, and the patient will basically be sent to a neurologist for what's called an EMG and nerve conduction study. And the EMG and nerve conduction study is fairly definitive in diagnosing cubital tunnel syndrome. One of the reasons that's important is because, for example, a pinched number 8 nerve in the neck could mimic a cubital tunnel syndrome in the sense that the number 8 nerve, if it's pinched in the neck, will cause symptoms running down the pinky side of the arm into these first two fingers. You'll often have a lot of neck pain associated with that, and you often won't have elbow symptoms with that, or you won't have a history of hitting your elbow or your funny bone. But it's always good to kind of rule out a number 8 nerve pinching because you don't want to go and operate on their elbow when it's actually coming from their neck. So a nerve test, the EMG and nerve conduction study, measures the healthiness of the nerve as well as the muscles that the nerve innervates. So not only can the nerve test tell us whether it's the C8 nerve in the neck being pinched versus the ulnar nerve in the elbow being pinched, but it can tell us where that pinching occurs. And usually it tells us that with something called a conduction block. And it basically measures the speed of electrical transmission along a nerve. And if it suddenly slows down between 2 points, then you can assume that at that point there is some kind of block or interference with the conduction of that electrical signal. And thus, a neurologist can usually confirm not only that a patient has cubital tunnel syndrome, but they might even be able to tell you, is that block or pinching occurring in the actual cubital tunnel, which is that groove in the elbow, or is it higher up than that in the exit point of the nerve from the muscles in the upper arm, or is it past the cubital tunnel in the entry point of the nerve into the muscles of the forearm? So the nerve test is really a definitive test that really is something I like to see, because it raises my confidence level that if I unpinch the nerve, the patient's going to feel better. And not only that, but where do I need to pay special attention to of where the nerve might be pinched. So if the patient comes into my office with the diagnosis of cubital tunnel, and they already have the EMG and nerve conduction study, that's pretty much all I need to offer them surgery if they're bad enough and they're not getting better. If they don't have the nerve test, I'll often send them for the nerve test just as confirmation. So along with the nerve test, the description of symptoms and where they travel down the arm into the hand, physical exam findings like atrophy in the intrinsic muscles of the hand, weakness in particular muscles, the combination of all of those type things, including a possible history of an elbow injury or a bad funny bone incident, those are usually enough for me to be confident of the diagnosis, as well as confidence that if I do surgery to unpinch that ulnar nerve, the patient's going to feel better. So that's typically the process of what a patient will go through in my office to get that diagnosis of cubital tunnel syndrome from me, as well as my willingness to offer them surgery for that problem. So unfortunately, there are not a lot of great non-surgical treatment options for cubital tunnel syndrome. If there is not a band of scar tissue there, or if there is not a history of trauma, and the irritation of the ulnar nerve is simply due to pressure on that area of the nerve from some type of activity, then you could get away with just stopping that activity or adjusting some things regarding that activity and avoid surgery. And this could be, for example, if you work in a computer or on a computer a lot and your elbow is in a position that nerve is constantly being irritated. In that kind of situation, you could simply get some special gel padding to put under your elbow so that when you're working on the computer, you're not bothering that nerve. If, for example, you work in a factory or you're doing some kind of job where that elbow is always being pushed on, you could adjust things to try and decrease pressure on that part of the elbow. Other than padding and avoiding repetitive traumas to that nerve in that spot, there's not really much you can do as far as taking a pill or doing some kind of therapy. So that leaves the surgical option. And the surgical option is basically unpinching that nerve. And that's called a ulnar decompression or cubital tunnel release. Now there are technically two ways to do that surgery. One way is by simply finding the nerve, visually looking at it, following that nerve along its course from where it leaves the muscles in the upper arm to where it enters the muscles in the forearm. And any spot during the course of that nerve, you basically unpinch. If there's a band of scar tissue kinking the nerve, you basically cut or scrape away at that scar tissue so it's not pinching the nerve anymore. If the entry or exit points of the nerve and the muscles are tight, you basically cut those little tunnels and make those spaces bigger. If the nerve is caught on some type of connective tissue, you basically release the nerve. And that's basically a simple decompression. I actually prefer that type of surgery as opposed to the other type of surgery, which is called an ulnar nerve transposition. And that's where you actually move the nerve from the cubital tunnel to a different spot, usually in some type of sling that you create out of other tissues, either connective tissue or muscle tissue, that moves the nerve out of that tunnel into a different spot. I don't like doing that surgery because, number one, studies have shown that the results between the two are really the same as far as improving symptoms. Number two, the transposition surgery takes longer. And number three, the transposition surgery puts the nerve more at risk of injuring branches or the blood supply to the nerve. So if the results really aren't going to be any better, why put the patient through a longer surgery with more risk to the nerve? So I really never or didn't do many transpositions of the ulnar nerve. I did simple decompressions. And that surgery usually takes about 30 minutes in the operating room. You technically don't have to do that with the patient fully asleep, but I usually like to do that because it's tough for the patient to be sort of in la-la land, half asleep, not really asleep, and have the arm in this position for 30 minutes straight and not move it. So my patients are usually under general anesthesia for this surgery, even though it only takes about 30 minutes. So how would the patient get to the operating room if they had this problem and wanted this surgery? Well, we'd meet in the office, we'd pick a day, I'd go over what to expect before, during, and after the surgery, the risks, the benefits. If the patient is over a certain age, we might get some blood tests, an EKG, a chest x-ray, make sure they're healthy enough for the anesthesia. They'd show up at the hospital, they'd meet the anesthesiologist, we'd bring them into the operating room, we'd put them to sleep. We would put their arm in this position and put some padding underneath it here. We would wash the arm with we'd drape the arm with some sterile drapes and then wash the elbow area with some special betadine or chlorhexamine solution. And then you can see here, this is the cubital tunnel where the nerve runs through the elbow. And this is the incision that I would make in order to pull the skin down and expose that cubital tunnel, as well as where the nerve enters the muscle, or exits the muscle here and enters the muscle here. So I'd make that incision, go down to the bone, pull the skin down to the elbow to expose the cubital tunnel. And then once I exposed the cubital tunnel, I would palpate or feel with my finger that nerve running through the cubital tunnel. I would then lift up the connective tissue and make little bites in it with a scissor until I get into that pocket of space called the cubital tunnel where the ulnar nerve runs. And then I basically use scissors or a scalpel to open up the tissue surrounding that tunnel until I see the nerve in all its glory sitting there. And then I examine it for any scar tissue or bands of connective tissue crossing it, make sure those are cut free and the nerve is nice and free. And then I take a little probe and follow the nerve along into the point it enters the muscle, exits the muscle in the upper arm and enters the muscle in the forearm. And I make sure those areas of entry and exit points are not pinched or tight in all positions of the arm being bent and not bent. Any spot that's tight, I basically cut that with scissors and cauterize the edges to make it shrink back. So now I'll kind of grab the connective tissue covering the outside of the nerve to kind of lift it up and examine the back side of it, make sure there are no areas of compression or adhesions, and then basically wash out the area, cauterize any spots of little bleeding, put in a couple of stitches under the skin that dissolve, and then a bunch of staples along that incision line, and then put on a dressing. And that whole surgery to unpinch that nerve takes about 30 minutes. And that's pretty much the surgery to unpinch that nerve in the cubital tunnel. Now keep in mind the surgery for cubital tunnel syndrome is a very good surgery with low risk and good results. The results are not quite as good as the surgery for carpal tunnel syndrome. And in the books for cubital tunnel syndrome, you're looking at a good result in about 60% of patients, a fair result in about 20% of patients, and a poor result, which means they either have no improvement of their symptoms or continued worsening of their symptoms, in about 15%. So overall, still a pretty good surgery for that problem. I can also tell you that patients who don't have a lot of weakness but have a lot of pain, numbness, or tingling tend to do better than a patient who has a lot of weakness. Patients who have a lot of weakness tend to have injured the nerve more than patients who don't have weakness. So that's pretty much the surgery for cubital tunnel syndrome. Before we go on to, actually let's talk about the risks too before we go on to some images and pictures. So the last thing I talk to patients about before I ask them whether they want the surgery or not are the risks of the surgery. There are 3 risks for this surgery, and these 3 risks are the same no matter what kind of surgery it is. It could be a heart transplant, brain transplant, ingrown toenail surgery, same 3 risks. Infection, bleeding, problems with anesthesia. All very low, especially for this kind of surgery, but those risks are in the books. And that's why we get blood tests, EKGs, chest x-rays, those kind of things, make sure you're healthy. We do the operation in a sterile operating room environment. That lowers the risk of infection. There's really not a big risk of bleeding for this surgery. There aren't any big major blood vessels near where you're working. So those three risks that are really for any kind of surgery are very, very low for cubital tunnel release. Now there are some risks that are special to this surgery because you're working near the nerve. And those risks are basically any kind of injury to that nerve, whether it's sensory fibers or motor fibers. If you injure the nerve in the sensory fibers, you can get numbness, tingling, or pain in the distribution of that nerve. And of course, if you injure the motor fibers, you can get weakness in the muscles that nerve innervates. Knock on wood, I've never done that to any of my patients, but it's in the book, so I have to tell you about it. And keep in mind, that's an important reason for your doctor to document before the surgery what kind of motor weakness you have and symptoms you have, to really document what you've already done to that nerve with the injury that you have. And those are the 4 or 5 risks to that surgery, which are relatively, again, low for this kind of surgery. So before we finish up, let's take a look at some pictures to kind of show what the nerve looks like running in the position of the cubital tunnel, as well as what the surgery does, and give you sort of a better idea of what those things look like on diagrams. So let's take a look at those pictures. So let's take a look at where it hurts or gets numbness and tingling or symptoms from cubital tunnel syndrome. And here we can see on this image the cubital tunnel, which is where the nerve has this red discoloration around it. So this is where it's going to hurt to the touch. And then if you get pain from that nerve being upset shooting into the arm, it'll follow the path of this nerve into these 2 fingers. And then numbness and tingling will be in this purple shaded area. And again, this is the pain, numbness, and tingling distribution of the ulnar nerve. And again, when you do get pain, it's an aching sensation and it will course through the entire forearm, although it doesn't show this on this picture. So this is where pain, numbness, and tingling will occur from a pinched ulnar nerve in the cubital tunnel. So here we've got sort of a picture of what it might look like right before and during surgery. So in this case, the picture on the left, the purple line is the incision I would make. It's hard to see the nerve underneath here, but this is the entry point of the nerve into the forearm musculature. Here's the exit point of the nerve from the upper arm musculature. If I make an incision like this and peel this down to here, I would then expose all of this. There's a little band of fascia or connective tissue here that often is pinching the nerve or scarred from previous injury. So I would cut this piece of fascia, I'd cut all the connective tissue in here to be able to visualize the nerve, and then if we look over on the right, you can actually see the nerve. Here's the band of fascia or connective tissue cut. This little tunnel here would be explored, and if that was too tight, I would cut this. If this was too tight up here, I would cut this. And I would inspect this nerve all along its path, and typically I'll find a band of connective tissue here, like you see this being cut here, that's kinking or pushing on the nerve. So I would release that. This purple line here is an example of where the nerve might be put during the transposition type of surgery, where I mentioned the nerve is actually moved out of the cubital tunnel and put in a different spot and would be tacked down into that new spot. Again, I don't really like doing that surgery. I don't think it's necessary or that it is worth the risk associated with it. You can just get the same result by just inspecting the nerve and decompressing it. So again, once the nerve is nice and decompressed and these 2 tunnels are explored and made confirm that they're not tight, this gets all washed out with antibiotic saline. Little blood vessels that might be bleeding a little bit would be cauterized, and then everything gets sewn up. And then finally, another type of picture showing a surgery. This is not quite the incision I would make. I don't like the incision to be over the nerve itself. But here you can see the nerve exiting the upper arm, entering the forearm, You can see these little tunnels of fascia that can cause kinking or pressure on the nerve. Here's the Osborne's fascia again. This is often a spot of pinching, or if there's previous trauma or injury, it could be anywhere along this tunnel. But this yellow band is the nerve, and you can see all the musculature nearby. But this is another diagram of what the surgical field would look like. Okay guys, so today's video is on Cubital Tunnel Syndrome, which is pinching of the ulnar nerve in the elbow. That's the most common spot for that nerve to get pinched. We talked about why it happens, the symptoms you're going to get, your options including the surgery option, what to expect before and during the surgery, as well as the risks. I forgot to mention that after the surgery, the recovery is pretty quick for this. The patient usually goes home the same day as the surgery. I tell them to stay in the house for 2 or 3 days, and that doesn't mean lie in bed all day, but just stay home. They're allowed up and down steps, watch TV, read a book, take a nap, play on the computer, stare out the window, watch the grass grow, that kind of thing for 2 or 3 days. They're going to have a bandage around the elbow and then an ACE wrap around the bandage. They usually take the ACE wrap 24 hours after the surgery. I put that on just to put a little pressure on there to decrease bleeding or the formation of a hematoma. They'll be back in my office 2 weeks after the surgery to get the dressing taken off and the staples taken out to see me and to get an incision check. If the incision looks good and they look good, from my perspective, they've graduated, they're off the hook, they don't have to come back. Typically, the patient will tell me that the numbness and tingling was better by 2 weeks. If they had a lot of weakness, that typically will take longer to get better, and I usually tell the patient that it can take up to a year for weakness to get better. So in about a year after the surgery, they can look in the mirror and kind of tell themselves, this is what I'm stuck with. The more serious the weakness is before the surgery, the longer it can take, or the possibility that the weakness won't get better is higher. And that's particularly if the weakness has gotten bad enough that the muscles have started to atrophy or shrink up in the hand. So again, if everything looks good at 2 weeks, from my perspective, the patient does not have to come back and see me. I usually will tell them to call me if they need me, and I'll send their primary care doctor or referring doctor a letter and let them know how they did. So that's what to expect after the surgery. We talked about the risks, the surgery itself, what to expect before, during, and after, etc., etc. We looked at some pictures. So I hope this just gives you the basic information about cubital tunnel syndrome and makes you feel a little more at ease before you get your appointment with your surgeon to get that taken care of. I hope it was helpful. If you did think it was helpful, don't forget to like and subscribe to the channel. And then most importantly, don't forget, most important thing, stay healthy.